Hi, welcome back to this video series 59 on staying healthy. This is Professor Wimalawansa from United States and New Jersey. In this video, we are going to discuss about the second wave of COVID-19 that is in horizon, and indeed in some countries like China and a small part of Europe and in the southern hemisphere, this has already begun. Other countries likelihood that this will materialize within the next couple of months. So it's better to be prepared rather than being sorry as happened in the March-April period. So COVID could affect everyone from newborn to centurions without any color or ethnic or racial or economic bias. Some people get it worse and other people less, mostly due based on the innate immune system capabilities. Immune system is almost 70% run by the vitamin D, so therefore with the less vitamin D, the person will have a poorer immune responses, immune system, therefore inability to fight against COVID-19. So approximately the 70% of the population, mostly the young and even the older people with the better vitamin D status, and therefore having a reasonable immune system, either get asymptomatic disease or have mild flu-like illness secondary to COVID-19 requiring no medical attention. So these people will not be included in any of the COVID statistics as commonly happen in the tropical countries because they do not do any PCR testing. As we discussed, that's a spurious results and reported the cases and the deaths from tropical countries, as mentioned in the previous videos, need to be multiplied by anything from 10 to 40-fold to get the accurate data. So many of these people with a good immune system may not even recall that they had a COVID-19 like illness. So that's the scenario. Since the second wave of COVID-19 with a slight variant from the COVID-19 strain that we had during early this year, is already began to manifest globally. In fact, the latest bout of infection in China is a different variant. It's apparently coming from Europe back to China where it originated. Therefore, let's relook at some of the relevant key factors to remind ourselves what is going on, who should get infected, who is getting infected, and how can prevent it. So let's look at the immune system. Who gets a disease? Those who are having a better immune system enable to generate antibody quickly to get rid of COVID or can at least control the COVID, and therefore they will not develop any severe symptoms, cytokine storms or no deaths basically. This heightened immune system is a clue to staying healthy during the COVID epidemic. So I discussed in a number of videos the importance and how one could develop stronger immune system with the minimal or no cost. We are responsible for our own health and recovery, and you cannot and should not rely on the governments or health departments to do that for you, as they will not do and they cannot do. The good news is that not that difficult to boost our immune system with any person. In fact, excess of 95% of the people who can afford that. In developing countries, this must be subsidized and facilitated by the respective governments rather than wasting funds on curfew management, strengthening task forces and expanding health system, which has basically very little impact on COVID control. Whereas spending time, money and education through mass media will have a tremendous effect of controlling COVID-19 across their countries. But virtually no country is really doing such a basic and fundamentally important approach in control COVID-19. So about 15% of the people develop a milder flu-like illness that extends maybe a few days or a week with apparent full recovery without any medical intervention. In the absence of community testing, these infectious people are not included in the reported statistics, but they do spread the disease in the community, what you call the asymptomatic carrier derived community peaks or clusters. Despite the recent erroneous claim by the WHO that was later retracted, these infected groups are asymptomatic carriers of COVID and continue to spread COVID to others, especially in the air-conditioned confined rooms like movie theaters is a classical deadly example of a spreading of this disease. The genome of COVID-19 apparently has an insert of HIV-like genetic component, which yet to be confirmed. If this is the case, then it can further weaken the host immune system in preventing the destruction of the virus. So it's a protective mechanism by the virus to protect the immune system destroying itself. This could be one of the key reasons why COVID-19 is capable of causing havoc in these poor person with a poor immune system. If this is confirmed, I predict that there will be a longer term delayed immune related complication from COVID-19 later in fully recovered people. This could be manifest a month or even years later. Among those infected with COVID-19, only about 10 to 12% will develop significant health issues needing medical attention. Meanwhile, children, young adults, although getting little or no signs and symptoms from COVID-19 infections, are carriers, in fact, the main carriers of COVID spreading to others. They can transmit the virus to others without their knowledge, including teachers, parents, grandparents, neighbors, and indeed any older relatives or people who they come with contacts. That's included in the shopping. So it is not just shutting down and opening schools and universities as authority believes. It's a lot more complicated than that to protect the elderly and the vulnerable. So let's also briefly address the importance of community testing for COVID-19, which is not done by any of these tropical countries which I mentioned in the previous video, who claim that they have such a low incidence and the death rates is COVID-19 simply because they do not test for COVID-19 except for the selected group of people in hospitals. So this is a very misleading statistic. Results from community testing and multiple studies reported, especially such as in Santa Clara and Los Angeles, New York City studies, and also in South Korea and Japan, all suggest that each PCR positive hospital patient, there is likely to be between 10 and 40 asymptomatic infected people in the community. Remember that these large number of people with the COVID infected are not included in statistics unless the country is doing community-based testing. Countries like Sri Lanka, Bangladesh, India, Indonesia, they don't do any community-based testing. Therefore, to get reasonable information, the total reported cases in a given country must be multiplied by, on average, about 25, as the range is between 10 and 40 people affected in the community per one PCR test positive person. When such average community infection is used for data explorations, there are between 15,000 and 60,000 COVID-19 infected people, for example, in Sri Lanka, not 1,500, with an estimated average of 37,000 people already infected in the communities in Sri Lanka, but undetected because the government is not doing community-based testing. And these people have a very mild or no symptomatology because they have already have a relatively relatively strong innate immune system because of the sun exposure throughout the year. Only a minority, about 10% of the people, come to medical attention, and therefore testing is done in these tropical countries and therefore included in the statistics when they admitted to hospital. Moreover, in hospital and even those who are admitted to ICU with respiratory issues and older people, is my personal experience seen, PTS testing is not done routinely. This is shameful, and this is happening in many of these countries. Under these circumstances, many COVID-19 diagnoses are missed, and those who are dying or dead are labeled with other diseases and not COVID-19. So it is no wonder that the death rates are so low because they are not diagnosed, and therefore death is reported as a heart attack or some other disease. So it's very misleading information reported by these countries to the WHO. Thus, no wonder such low numbers are reported in tropical countries. So no mystery now. As mentioned, most of them are asymptomatic and are not diagnosed because they are not subjected to PCR testing. So if you use with a 1.5 conservative death rate as stated by the WHO, the current expected number of deaths in Sri Lanka directly related to COVID-19 is in the excess of 560 deaths. Yet the official reported death toll is less than 15. So you can think about and understand why this is such a discrepancy of reporting and the estimated reality of this issue. So in the next video, I'm going to explore the reasons for this major discrepancy and why the reported and the real cases are so wide, sometimes 2 orders of magnitudes different. Till then, have a great day. Thank you. Bye.